Good afternoon to everyone and welcome to our new edition of this G-ScarS webinar. Welcome, bonjour, Professor Theo.
Bonjour.
Bonjour. Please let us know from where you are watching us. And if you have some questions, you can write them on the YouTube channel, on our YouTube chat, and we can read them at the end of every single lectures and answer to you. Professor Theo, if you want to give a welcome.
Yeah, welcome to everybody. This is a very important webinar from G-ScarS, seeing the interest of lasers in post-op scars, which is a very new topic into which many countries have already got a strategy with an early access to the lasers. So I think this will be an important webinar, and I give the talk to Carlota, who is very aware of these new technologies.
Okay, thank you very much. This afternoon we have three speakers, and I started to introduce you. The first one, Professor Ofir Artzi, who is the head of the Center for Aesthetic Dermatology at the Tel Aviv Medical Center. Professor Artzi talks about lasers in congestive and inflammatory scars. So please, Professor Artzi.
So thank you very much, and hello everyone. Hello, Professor Teot, and hello all the speakers. So I will be talking about it. It's really a great pleasure and honor to be part of this G-ScarS meeting, and I will be talking about scar mitigation and lasers, and I will talk about the early laser treatment, mainly the early laser treatment in inflammatory and congested post-operative scar. I have no relevant disclosures. So every deep, we're talking about, of course, every deep cut will will initiate this complicated three-step wound healing process. And if everything is normal, it will eventually result in fine, hypopigmented linear scar. Any interference to the wound healing process might result in abnormal scar, and we usually talk about hypertrophic scar or keloid. So, of course, scars can be treated. I'm sure you can appreciate the before and after. And if you want to do so, you have to combine between physical modalities. They have to be physical, surgical, and non-surgical modalities, different drugs, medications, and of course, different energy-based devices. Which devices? First, I have to refer you. I was privileged enough to be part of this important publication that came out 2 years ago, nearly 2 years ago. And for the first time, it talked about traumatic scars and contractures. So the first time it was put on writing that lasers, they play the first line, or they are the first line therapy in the management of traumatic scar and contractures. And if you don't have access to lasers, if we talk about scars, you are not getting the best available care after surgery. You have to combine between different laser types and between different medications. Which medications? Again, several. I will not get into details because I will focus in a minute just on mitigation, but I'm sure you're all familiar with steroids, Kenalog, and 5-FU, but the list is much longer. You can apply the drug topically, you can inject the drugs into the scars, and then you can use different energy-based devices in order to enhance delivery, to enhance drug delivery. Lasers or laser-assisted drug delivery. This is by far the most known energy-based device-assisted delivery system. However, there are more. For example, pneumatic needle-free jet injection, in which you create kind of what we call bumps in the scar, and I'm sure you can appreciate the result. And there is the TMFI technology. We create kind of dehydrated tissue with low water content. We perforate the stratum corneum, we transfer heat into the skin. And in the end, there are several publications. We create free passage of material, of drugs into the skin. And it was shown just recently by Warapung Manuskiati from Bangkok that there is an advantage. So if you combine between, for example, TMFI and following by the application of triamcinolone acetonide as compared to just injection, you have really good results. So I hope I convinced you that we know to treat all scars. So if you combine the right modalities, surgical, medication, and energy-based devices, you can really achieve good results. But we all agree that if you want to actually have the best outcome, it's always better to prevent scars. And the meaning of it, that you want to treat scars, or you want to treat the pre-scars or the early scarring process. So to treat scars when they are congested and inflammatory, and thus, or then you can really prevent or you can mitigate scars. It's very difficult while talking about scar prevention to actually predict which of the following patients will develop abnormal scars. We all know that inflammation plays an important role in abnormal scar formation. And we do know, and several studies showing that blunted inflammatory response, for example, in fetus or in the oral mucosa or in different species. So if you have blunted inflammatory response, you will have no scarring, or you will have little or some or very little amount of scarring. So if you reduce inflammation, and this is the reason that current inflammatory or current mitigation strategies to prevent scars include several directions, but one of the main one is to reduce inflammation, for example, by the use of anti-inflammatory drugs. I'm sure you all know steroids, but not only steroids, but steroids play a major role. You can, again, this is the reason I was showing you the different energy-based device-assisted delivery system. You can either apply them topically, you can inject them into the wound healing area, or to the pre-scar, or you can use different energy-based device-assisted drug delivery. Although steroids are the first one, there are different other drugs that were used or described mainly in animal studies. However, we do believe that in the future we will have other, I would say, drugs that will mitigate, will prevent scarring. Another strategy is to create anti-inflammatory environment or anti-fibrotic environment. We do know that if we add moisturizers, so the hydration or the use of silicone-based products in order to prevent evaporation, to decrease the transepidermal water loss, if you keep your wound moist, you will reduce scar formation. And it was shown in different studies that the mechanoregulation is very important. So fibroblast behavior is known to be influenced by mechanical signals. So if you reduce the tension from the area of wound, from the pre-scar area, you will prevent, or you might prevent, scarring. Regarding sun, it's mainly for the prevention of hyperpigmentation, although we do see that with abundant sun exposure, we might actually create some abnormal scarring. But this was kind of passive strategies. We all know, and maybe one slide that I added just while preparing the talk. This is a recent study from Korea, and here you can see this is what we call active prevention. Two devices. One is the CO2, fractional ablative CO2, in order to reduce the tensile force, and the use of skin wound tension reduction device. And the combination, this is in the pediatric population, showed advantage. So we do know that mechanoregulation plays an important role. So again, in anti-inflammatory drugs and anti-inflammatory environment. I'm going to focus in this study, in this talk, on active intervention, and I will talk about the use of different energy-based devices. One Direction, again, this is quite new. It's still not available in most countries, the use of low-level laser therapy. We talk about a power density less than 500 millivolt per centimeter square. We know that it accelerates wound closure and it improves the tensile strength of scars. And again, preparing this talk, this is a recent publication, an interesting publication that showed the advantage of the use of red light in the wavelengths of 633 nanometer. And you can see that the area that was treated actually produced less scarring. So again, maybe in the future, a patient after going through a surgery will get some home use device with a red light, but there is a role for low level laser therapy. But I'm going to focus about lasers. There are two main reviews that was published in recent years regarding the value, the importance of early laser treatment for the mitigation of scar. One was published by the group of Miret Hadersdal from Denmark, and one was published by our group. And I just want to show you that if we take all articles that were published on the subject of post-surgical scars, and we talk about mitigation or scar prevention, you can see we included publications from 1995, and we focused on surgical scars. If you take all publications that really scored, so we talk about split scar study on which half of the scar was treated with lasers, so early intervention with lasers, and the other side wasn't treated. And we took, because there were few scales used in the different studies, so we normalized the different scales into one scale, and then we can actually calculate the results of 1,004 scar measurement. And you can see this is the patient scoring as compared to the physician scoring. There is a value for the early intervention of lasers if you want to mitigate, or if you want to achieve better cosmesis, better final scar cosmesis. Which lasers? Probably the main laser is pulse dye laser. We talk usually on short pulse duration and small spot size and very low energies, maybe because of the selective destruction of scar microvascularity. So we create kind of a less cytokine environment. So we will have in the end less inflammation and less scarring. Other lasers which have role in scar prevention are fractional lasers. We talk about non-ablative fractional laser, but mainly fractional ablative lasers. And I think the main one is fractional CO2 laser. Most publications show the advantage of early fractional CO2 laser. It might minimize scar. If we look at the different data, and again, our publication came out in 2019, so you see that there were few publications which combined between two lasers. So there was an advantage for the combination of two lasers. And actually, this is after our publication. This is a recent publication by Kim, 2021. And again, if we combine, and he showed that if we can combine IPL and fractional ablative erbium YAG, this combination has a value as compared to monotherapy. So probably there is a role. I want to refer you to our work. This is a work that was published in 2019. It was a collaboration of the Department of Oncology and our department, the Department of Dermatology. And what we did, it was a prospective randomized double-blind split scar study. 19 healthy female patients who went through lumpectomy. We saw our patient 2 to 6 weeks after surgery. We randomized the scar, so just half of the scar was treated randomly actively by the combination of pulse dye laser, and just on the area of uneven surface or high skin tension, there was focal treatment with the fractional ablative CO2. And again, I will not get into details because you can read this publication, but I'm sure you can appreciate if you compare between the treated area as compared to the non-treated area. We showed, we demonstrated the value of active intervention with these two lasers, pulse dye laser and fractional ablative CO2 laser. If we go back to our review, several studies demonstrate the efficacy or the value of combining between lasers and drugs, mainly triamcinolone acetonide. And again, this is not part of our publication. This is a publication from a month ago in the JCD 2022. You can see that if we combine between pulse dye laser and injection of triamcinolone acetonide, this combination it is more effective as any monotherapy. So maybe there is a role for the combination of lasers and drugs. Which drugs? Again, I'm sure you all know the Kinalog 5FU. It's another drug, maybe not in the very early phase, but again, the list is very long. If you look at the different studies, there are drugs which showed no efficacy. You have drugs which showed some, I would say, contradicting or inconsistent efficacy. I will just have to maybe mention the onion extract gel. Again, there were some studies showing the efficacy, and maybe botulinum toxin. This is the last one in the ISAPS, showing again different review of different studies, different doses, and you can see this is the summary. Therefore, botulinum toxin can be considered effective in preventive scar formation and improving scar quality. So mainly in the face, mainly in area of higher skin tension, higher tensile force, there is a role for botulinum toxin for the treatment or for the mitigation of scars. Now, when to begin, and then I will share with you our protocol in the hospital. I think we now know, and this is as compared to the past, if you go back 1995, 1999, you can see that all studies actually recommended to wait. So wait 6 months, wait 1 year. This is no longer the recommendation. The majority of studies, and this is I painted them, I marked them in yellow color. So most studies support the early intervention. We talk about 2 to 4 weeks after surgery or around suture removal. It will provide you with the best aesthetic outcome. So this is the standard of care nowadays. But I have to say that if we think of the future, this is kind of science fiction. Again, this is a study that you can read. It was published 2 years ago in the J-PRAS. And in this study, what we did, we pre-treated the future surgical area. So you can see it was patient who went through the removal of lipomas, big lipomas in the neck area. So 24 hours before the excision, they were marked. You can see the area of excision and the area of future scar. This is the AB. So half part was treated actively with non-ablative fractional laser, and then 24 hours after the laser treatment, the patient went to go through the operation, and we followed our patient. It was altogether 11 patients and 12 months follow-up. You can see the picture B is 1 month following the operation. C is 12 months following the operation. And I do have to say that with all patients, we saw that the pre-treated area demonstrated better result. And I do have to say that, again, maybe this is the future. There is a study not about laser. There is a study by Bashir Bayat from Cape Town, and he started talking about priming the skin. He talked about different drugs, and we can see that more and more we think about scar prevention, but even before surgery. But again, it's still not the standard of care. So what is the take-home message? And then again, if you have any question, I will be more than happy to answer you. But it's very difficult to predict which of the following patients will develop abnormal scars. I'm sure you all know, and you have to be familiar with the risk factors for scars. We talk about risk factors which are patient related. So certain patients are more prone for scarring, for example, high dark skin type, high Fitzpatrick type 5 and 6, but we talk about certain operations in certain anatomical areas that are more prone for scarring. And I'm sure you all understand that every interference, so the main issue, and I showed you the wound healing process, this is one of the main issues while talking about scar prevention. And if we can reduce inflammation, we can actually mitigate scar. If you're not convinced, this is again a very recent publication from the PRS, and this is among different surgical specialties. And please have a look, with up to 91% of patients wishing for even slight improvements in the appearance of their scars. So talking about scars in general and scar cosmesis, they play important roles. Scars pose, it's not just aesthetically importance, they impose many issues, either personal or at work, or many issues. And we talk about just the aesthetic, I would say, aspect. Some scars are really painful, itchy, and of course, some scars are associated with what we call physical morbidity, so contracture. So scars are important to prevent, and this is the reason we have to try and prevent them. I hope I convinced you that most data support the early intervention, and I'm talking about mainly laser treatment in the period of wound healing. So you should treat congested and inflammatory scars or pre-scars. I do have to mention that once in a while, this is a publication that came out in the last year, that actually this publication reviewed the literature, and again, the sentence is on the basis of currently available evidence. We are uncertain about the effect of scar prevention, but again, I think most data support the early intervention, the early laser treatment. And again, what do we do? And this is our strategy. That's what we do in our hospital, not for every patient, because it's not cost effective. But if it's a high risk situation, so high risk patient with a personal or family history of abnormal scarrings, if we know it's an operation that is more prone for scarring, or if there is any problem with the wound healing process, we start as early as possible. Which treatment? We first try to regulate the tension, so we decrease the tension as much as possible. We use lasers. Which lasers? I showed you. We have this after demonstrating, after proving with our study. We use usually the combination of pulse dye laser and focal fractional ablative CO2 laser, and we inject drugs. Mainly we inject triamcinolone acetonide. We usually inject it in very low dose, so 5 to 10 milligram per milliliter, or we use the different energy-based device-assisted delivery, mainly the laser-assisted drug delivery system, and then we don't have to inject. And again, with that, I think, again, this is that's what we feel, but this is the science and the studies. We feel we can mitigate. We cannot fully prevent, but we can mitigate scars. And again, this is our early mitigation, early treatment in the face of inflammation and congestion. So that's how we treat inflammatory and congested scar. So I'll stop here. Let's stop sharing, and I'll see if there are any question. Okay.
So thanks, Professor Arzi, for this interesting speech. And I think that it's very important that you have evidence that every single treatment has to be customized on patients. So we have to think about this. We don't have a standard thing, but we have to customize something. So let us see if we have some question for you. Yes, we have some questions.
What do you use Dormitory as well in clinical outcome studies? Do you use? Not really. Not really. I have to say that we don't really see, but most of our study, especially we didn't really use measurement. Now we have study in which we use 3D cameras. Again, initial results, but we see a role for active prevention. There is a link for the Mark. Again, I do not know the person, but pulse dye laser for burn scar. I talked about, my topic was mainly surgical scar, but it's the same for burn scar. So early treatment with pulse dye laser. Again, we see scar prevention. Does erbium? There's Kenneth who asked. Does erbium YAG create less thermal injury? And if so, isn't it preferable? So they're not. We don't have comparisons. So there are no studies really compared erbium YAG to CO2 laser, so fractional erbium to fractional CO2 laser, while talking about scar prevention. But I do have to say that it's not because of the thermal damage. What I'm trying to achieve, and I'm using a certain device which create really a very narrow and deep channels in areas of high tensile force, and I don't think that erbium YAG really create it. It's more superficial, and I have less experience with erbium YAG in general. Thank you, Mark, for the compliment. And can you elaborate on how you perform? Yeah, sure. What we do, it's very easy. It's different while talking about scar prevention and scar remodeling, but while talking about scar prevention, what we do, and again, it depends on the different, if it's a very early wound, let's say 2 or 3 weeks, we just use the pulse dye laser. My setting is 7 millimeter. I use 0.45 millisecond. No financial interest. Again, I'm just saying the setting as is. 0.45 millisecond, and I use usually 4 to 5.5 joule per centimeter. And then what I do, I just on the areas mainly for more older scars, so let's say not 2 weeks but 4 weeks, I just go on the area, either the area of the ear dog, so area of uneven surface, or area that I see some, let's say, tension. I usually we use in my hospital, again, no financial interest, we use the Encore by Luminis. What we use 12.5 millijoule, and we use usually either 3 or 5% coverage, and we just apply triamcinolone acetonide, usually 20 milligram per milliliter, and we have really good result. I think we are done, right?
We have another question from Mark Brewin. Why do you use 7 millimeters and not 10 millimeters?
That's actually a good question, and you know you can use 10 millimeter as well. However, if you look at the different studies, actually most studies they recommend the use of small spot sizes, so 5 and 7. So 5 for me is too harsh. As far as I'm concerned, 10 is a little bit deeper, so I use 7 and I have really good result. I haven't tried 10, but I don't think so. If you use 10, for example, 0.45 with very low energies, I believe you're going to experience the same results.
Okay, thank you very much, Professor Arzi, and go to the next speaker. If I have Professor Hansinger, Vincent, welcome with us.
Thank you.
Professor Hansinger is a plastic surgeon who works in Paris. And this afternoon, he talks us about lash technology, how to improve our surgery scars. And please, audience, don't be shy and make your question on our chat so we can answer to everything you want. So please, Dr. Hansinger.
Thank you. Thank you very much. Can you hear me? Everything's
Yes.
okay? Okay, great.
Yes, we can hear you and see your slides.
Great. So I am a plastic surgeon, so I'm sorry, but I'm not an expert of laser technologies. But there is one laser that I use since 5 years that I will speak about. And this laser is very interesting for us, for the surgeons, because it acts at a moment very interesting in the healing process. I will explain you everything in this presentation. And I will show you some results, some studies, and the concept and principle of this technology. So first of all, the question was in our surgery, in the plastic surgery, to have the best scars. It's always for us a goal, a very important goal. And the best scars for the surgeon is always different from the best scar for the patients. So the best scar for the surgeon is a scar with a very thin scar, which is in a good place and which is not very, which is strength. So the patient is very different. For the patient, a good scar is no scar. So this is anything we must very consider. We must consider it because 60% of the patients are not satisfied of their scar, which is a very big proportion of the patient with surgery. And for us, it's very interesting and important to give the best scar with surgery techniques, with the stitches, with all the surgical technique we use. And also we have now a technology that can improve the reaction of the skin, because we didn't have any possibility to get a better reaction, and we just now can act with this part of the healing process. What is the LASH, the Laser Assisted Scar Healing Technology? This is a technology which acts from the beginning of the healing process. So on the moment of the surgery, we make the surgery and all the sutures. And at the end, when everything is over, we can use this device. It's a laser shot of special wavelength of 1210 with a controlled rise of the temperature. And this is a very important thing to control the temperature, because if we don't, there is a risk of burn of the suture, of the scar. And it makes an activation of the heat shock proteins. The heat shock proteins are very interesting for us because these are proteins that can lower the process of inflammatory process post-operative. So from the beginning of the healing process, we can use this device, and the effect is an early inflammatory phase, which is low. It reduces the inflammation, and it gives better organization of the collagen fibers. The effect, the long-term effect is interesting too, because it makes a reduction of fibrosis and improves the scar. We will just see after how we can know this in a very scientific way. So what you can see here is all the process of the healing from vasoconstriction, coagulation, and all the steps. And to act early, the goal is to shorten and soften all this phase. So all of this will be shortened because most of the time, when you go to see the dermatologist laser, they can act and they can do some lasers to give a better scar, but they arrive after the fight, if I can speak like that. So the very interesting thing is we act just before the beginning of the healing process. Just for history, this technology began in 2008, and the first name was Equilight, and the wavelength was a little bit different. 810, it was the first person who described this mechanism. And with this wavelength, they had improvement of the scars, but with other problems we will see just after. And after, this laser was changed for a new wavelength of 1210. And it's very interesting because we can use it on all phototypes, even the black skins, and it will give more safety for the shot. And the SLASH study which is very interesting for his design and the results was made with this device. So this wavelength was chosen because it's the best one for absorption spectrum for the different skin chromophores, and it can be realized on all the patients from white to black, and everyone can do it with safety. Before, with the old wavelength, we had some burns, and so that's why now it's very interesting to do it with these parameters. This technology has now many clinical studies and scientific publications. So I just let here the reference, and if you want to know more, you can see them. Now the SLASH study, it was for me the real proof of the safety and the effectiveness of this technology, because the design was double-blind and randomized controlled trial. So it was a very interesting point to understand this technology. And the trial was made on 40 women. Each woman had bilateral breast reduction, and we see exactly the difference between one scar and the opposite side. So that is very interesting, because you don't have any parameters like the surgeon, the suture, or the patient who will do some false result. And the treatment application was exactly the same. So at the post-operative phase, you just do the laser at the end of the surgery on the horizontal scar, and after we take measurements of the volume and some parameters we will see just after. First of all, the demographic data. You can see there was some patients with high blood pressure. Most of the patient was phototype 3, but also you had 4, 5, 6, and all the phototypes were represented on the study. What we can see in the results is an improvement of the scars on all the patients. You can see one example, but I will show you more. And the most interesting thing is the volume of the scar and the roughness of the scar was reduced, and the difference was significant. So you can see one result, and the parameters, interest parameters, the scar volume, like 30% of reduced volume, the surface more than 10%, and the roughness almost 20%. The pictures and the measurements was made with a very special device. The name is Quantificare, and this device take the 3D volume of the scar, and it can do a real comparison of the volume, and to have real numbers, not just evaluation of surgeon, which is the most studies, which is the most often studies you can see. The patients also prefer the treated breast. That's very important for me, because if you have a good technology and you see that there is a 20 or 30% less of volume, but when you see with your eyes or with the patient eyes, you cannot see any difference. This is really not very interesting technology. But here, the patients didn't know which breast was treated or non-treated, and as we can see, we from the 6th week to the 50 week, you can see the patients all the time like the treated breast, and he didn't know which breast was treated. So for just a few examples, you can see on the right side the treated breast, and on the left side the non-treated breast. And which is interesting is all the patients has a different healing process. And as you can see, some patients with the laser will have scars, less quality scars of patients without laser, but with best healing process. So what we can see objective on this slides and this study is each patients, even patients who have good healing or bad healing process, they have benefit to do this laser. Someone have a benefit, but you have a good scar and a very good scar. Someone, some patients, you have a bad scar, for example, on the patient 8, and the scar is less bad when the scar is treated at the beginning of the healing process. So this is very interesting for the patients, this kind of pictures, to understand that each patient has his own healing process, and it's not the same for each patient, but the lash technology will improve this healing process and will give better scar with less volume and less visibility of the scar. So here, one patient of the study with 12-month follow-up, and you can see the week 0 just in the operating room at the end of the surgery of breast reduction. And you can see that the difference on the first weeks of the healing process is not so different because the inflammatory effects come later. And after 1, 2, 3 months, you will see the difference is bigger and bigger. And at 1 year of the healing process, you can see the treated breast on the right side, which is the left breast, is less visible for the scar than the right one. So very interesting for the healing process and for all the steps of the inflammatory process of the healing. Last thing, I will give you my personal experience, which is 5 years of Ergotouch laser use. And I must say, for me, this technology has make a little revolution, because despite of the suture techniques and what I can do to have the best scars as possible, the patients have really a possibility to act and to participate for a better scar, and they are very happy with that. And they have a very good acceptance of this technology, even if the cost is, of course, more expensive than when we don't do the laser. I made a small study in plastic and reconstructive surgery to explain my technique of minimally invasive inframammary breast augmentation, which is a technique I developed to make short scars from 2 to 3 centimeters for all the surgery of the breast augmentation. And with all the steps I described, the last one was the lash technology, because even a small scar, the patients want always to have the best scar as possible, and the less red scar, the less big volume scar. And you can see the scar in the operative room, and after 6 months, which is a very discreet scar. After I made some clinical case reports, and this is one you can see from the pre-operative ptosis to 12 months follow-up. And you can see the scars that are very thin because they were not red, they were not in volume, and the final scar is better. Another example with another ptosis, and I added implant and breast implant with the ptosis, and you can see also the T scar, inverted T scar, which is very discreet, even few months after the surgery. And random cases report, I can show you some cases. I'm sorry, the presentation is modified by the software, I think. So one breast reduction, and you can see we are at 5 weeks post-operative, and the scar is not red. And what I can see all the time, that most of the time the scars are red, and after they become rose, and after white. And with this technology, most of time they are not so red, and they just stay like gray, and after they become white. So it's almost at the early time good scars. One other scar at 7 weeks, so it's very early, but as you can see, the vertical scar is very discreet, and we are not so advanced in the healing process. Mastopexy with breast implant. This is the result you saw just before. Breast reduction at 4 months. Okay, so you can see at 4 months you have a result. I think without laser I had at 1 year before. So at 4 months you don't have any inflammation. You have white scars, and you have very discrete scars. Breast augmentation, we make sometimes the round block scar. This is a scar all over the nipple areola complex. And as you can see, the scar is less visible. And I must say the laser, the lash is very, very interesting for these scars, for the peri-areolar complete scar, because it is very thin and you cannot even see it. And we are just at 5 months of the surgery. This scar on a tattoo, so difficult to make exact the same position, but you don't have any enlargement of the scar because you had less inflammation of the scar. Another breast augmentation, but the submammary fold with the mini-BA technique, and as you can see, the scar is not very visible. Mastopexy without implant but with lipofilling, so with breast with a fat injection at 11 months. So this is white scars and very discreet too. And my conclusion is this process is not perfect. So in some patients who have a very, very difficult healing process, you can also have difficult scars. And with the difficult scars I have on postoperative evolution, I give them to some dermatologists to do some laser, non-ablative or ablative to improve the scars, but much better and less patients who needs after scar correction. It's for me an additional weapon for the surgeon to act at the early phase of the healing process, just at the operating room for a best scar. It's not too long. I must tell it's the first thing the surgeon are afraid with this technology, but it's really not too long, and a very, very good acceptance for the patients who wants to act for a good healing, and who is very, very happy to participate and to ask for this laser. Thank you for your attention, and if you have any question, I'm here.
Thank you very much, Professor Hansinger, for your nice speech. We have some questions from the audience. Dr. Carlo Colla from Belgium asks you if you can reduce the width of a hypertrophic scar with this technique.
In fact, I can reduce the width of a hypertrophic scar if I do a new scar. So you cannot do this laser on an existing scar. The existing scars must be treated with conventional technologies, laser technologies. So when I see a patient with hypertrophic scar, first of all, I wait a little bit to see the evolution, and if the evolution is not good, I can do a new surgery to remove the scar and to make a new suture and to apply the laser on the new scar. But you cannot do this on an old scar.
Okay. And we have another question from Kenneth Dolinchuk from Canada. What do you think about vessel shrinkage as a cause of red reduction of your post-laser scar results?
I'm not sure to understand exactly the question.
I think that Dr. Dolinchuk asked you if you can think that that could be a shrinkage of vessels as a cause for the reduction of the redness that you can observe after your lasers.
During this process of the lash technology.
Yeah.
I think the process is really the liberation of the heat shock proteins, and these proteins has a very important panel of actions. So maybe this is one part of these actions. but the most important action is to lower all the process of inflammations. This is, I think, one part of these actions.
Okay, I have a question too. The audience is shy, so I have a question too. You said that this kind of treatment is not cheap. Okay, it's not a cheaper one. So if a patient doesn't want or do this kind of treatment, which is your protocol to prevent a bad scarring?
Okay.
Do you use other device like I don't know, fluorescent light energy or other things, drugs?
No, personally, I use very classic and conventional ways to have a good scar, and I must say I use them even with the patients with the laser. So for me, the laser is additional to all the other
Okay.
ways to have a good scar. And the first way to have a good scar is to have a scar with not a lot of tensions. So during the surgery, I make very I make attention to have a scar with less tension. For example, in the tummy tuck, there is some techniques who can report the tension of the scar to other parts, and we make some inside stitches to make the upper tension and not the lower tension. So this is the first thing for the technique, surgical technique. After, what I use is some mechanical ways to prevent hypertrophic scars. So for me, the massage is one interesting thing, and the compression, silicone compression, is too interesting. So I always propose to make massage and silicone compression. If I have when I follow the patients up, if I see the scar with all of these is going to grow up, I make a prescription for dermocorticoids to make massage with an active dermocorticoid to penetrate the scar and to reduce the inflammations. I use almost never the injection of corticoid, because it's most of time too strong, and as it's interesting for very pathologic scars like keloid scars or really big hypertrophic scars. I think for most of patients, it's a very bad product with medical adverse effects, and I don't use it. And after, I give the patient, when I see the scar is not going the way I want, to some dermatologist or other doctors that do laser technologies.
Okay, thank you very much, Dr. Hansinger. So let's go to our last speaker, Professor Gerd Goglitz. He's a dermatologist who works in Munich. This afternoon, his speech is about the ablative lasers in hypertrophic scars and keloids. Please welcome.
Thank you very much for this kind introduction. My name is Professor Gauglitz, and I'm very happy to be able to discuss with you a bit on the use of ablative, mostly fractional lasers for the treatment of hypertrophic scars and keloids. I do not have any conflict of interest for this specific talk, even though when you do work with lasers, you are in close contact with several companies, but as I said, no conflict of interest for the specific talks. If we look into the guidelines that discuss possible treatments for the improvement of excessive scarrings, we do see a huge trend towards laser technologies. This is, I think, already reflected by the previous talks. When we look into the updated international clinical recommendations published in 2014, we already saw the pulse dye laser, which is till to date pretty popular in prevention, as we just heard, but also in treatment of especially reddish scars. And in these guidelines, the fraction lasers have been first introduced. Then we have the German guidelines that also recognize the importance of lasers. We published the update in 2020, and a big international panel of SCAR experts is publishing currently several papers on different SCAR types. And again, lasers do play a huge role in these publications. Nevertheless, there are different ways of treating different types of scars, including conservative treatments, injectables, and then different wavelengths. And here we really want to differentiate in between the target that you want to address. We have, for one, different wavelengths in targeting, for example, hemoglobin. So you create some hypoxemia, and they're pretty good for reducing erythema, and by that also indirectly reducing inflammation to a certain point and reducing collagen production. Then we have pigment lasers. This could be, for example, nano or picosecond lasers, which actually reduce the hyperpigmentation of specific scars, and they might actually have an indirect way also on collagen production. This is not completely clear to date. Then we have the ablative lasers that I just mentioned. We have two different ones. Mostly this is either the erbium-YAG wavelengths of around 3000 nanometers, and then we have the CO2 laser. There was a question previously. Indeed, an erbium-YAG laser is referred to as a cold laser, so it might be not as great for collagen remodeling. It is actually quite a good device for laser-assisted drug delivery. And then we have the CO2, which is the most popular one when it comes to collagen remodeling. In this area, we also have other wavelengths, such, for example, the 5040 to 5065 nanometer wavelengths, also referred to as erbium glass lasers, and they're actually quite good in introducing scar remodeling. The only thing is that they have a relatively shallow penetration depth. So when it comes to thicker scars, a CO2 laser is definitely superior to these erbium glass lasers. We are talking nowadays a lot about fractional lasers, and they are available for a lot of different wavelengths nowadays. To date, it's mostly about the ablative lasers. The idea in general is with fractional lasers that you only target a small percentage of the area you're treating with a laser. And when it comes to scars, you really want to go for low densities in order to prevent overheating the scar tissue. The idea is to mostly create some dermal remodeling. And as I just said, it's mostly the CO2 laser that is being used when it comes to scar remodeling. The mode of action of the CO2 laser has till to date pretty well elucidated. It goes pretty much about via the heat shock proteins, and they interact very closely with the TGF-beta 1-2-3 cascade. In the very end, to keep it basic, we do see a shift towards a normal dermal architecture when it comes to the treatment of hypertrophic scars. This has been also shown to a certain way for keloids and also for mature, let's say slightly elevated scars. But as you see here in the slide, the CO2 laser is indeed used for a lot of different indications as well. So if you are looking at this device from a practical point of view, if you're, for example, working with lasers, a CO2 laser is really a good device to use for many different indications. Even though I do not have any specific conflict of interest, I would like to highlight that when it comes to the treatment of scars, it is best to either use a super-pulsed or even an ultra-pulsed CO2 laser, because you really want to go for pretty narrow zones of thermal damage. This is best achieved with an ultra-pulsed laser. You have less downtime, less pain, and they are much more precise. You can actually work much more aggressively because you have these narrow zones of thermal damage, and by that you can work faster without overheating the tissue. And the other advantage is that you have a pretty high penetration depth. When you use specific settings, you can go up to 4,000 microns in depth, which is very pleasant when you're working with very thick, for example, burn scars. There are a lot of studies nowadays published on the benefit of a fractional CO2 when it comes to the treatment of excessive scars, mostly burn scars. And without going into too much detail to with these specific studies, you can actually see that if you look at all the studies available, in average, you can achieve around 50% clinical improvement after around 3 sessions with an ablative fractional CO2 laser. The histological studies confirm let's say the mode of action of the CO2. The histological studies do demonstrate a normalization of the dermal architecture in scars created with a CO2 laser. So we do see that on different levels, there's something beneficial going on. There are other studies going more from a clinical point of view on benefits on texture, for example, or scar thickness. And there are also a couple of studies that do show significant improvement after several treatments using a fractional CO2 laser when it comes to these characteristics of a scar. Most importantly, I think, is the measurements of patients' life quality. They do improve significantly upon a CO2 laser treatment. This has been shown nowadays in several studies. What we have to keep in mind is that scar remodeling takes time. There are several studies having highlighted this fact. For those that are familiar with the CO2 laser may have used it, for example, in other indications, such, for example, skin resurfacings in healthy women, for example, or men. Do know that the improvements that you see after CO2 laser treatment actually do take time, and even healthy skin. They usually take up to 9 months. So it's, I think, logical that in scar tissue, which is not being considered completely healthy skin, these remodeling changes might take even longer. And this study that I picked here actually demonstrates this very nice. This is a patient cohort that has been suffered from severe burn injury with resulting hypertrophic burn scars. And this patient population has been treated a total of 3 times with either pulse dye laser or CO2 laser. And you see here the 5 months follow-up. And I only want to refer to the changes based on the Vancouver Scar Scale, which have been highly significant 5 months after the last treatment. But more interesting is that another 30 months later, without any additional treatments, you see a further improvement based on the Vancouver Scar Scale, which highlights the fact that scar remodeling takes time, and it takes time sometimes up to 3 years. And this is what I actually do with my patient population in my clinic on a frequent basis. I like to do breaks in between treatments, also in order to give the scar tissue time to remodel. So we usually do over summertime a half-year break in order to give the scar tissue time to improve and to settle down. We did a study using the CO2 laser only once in a very, let's say, sensitive study using a lot of different objective measurements, such, for example, the primers or the vector devices, which are kind of 3D measurements, objectively measuring scar height, scar texture, scar volume. We also use Q2 meter, for example, Vancouver Scar Scale POSAS, the Dermatologic Life Quality Index, in order to see if a single treatment using the ultrapulse CO2 laser does make a difference compared to a comparable untreated skin area. The idea was of this pilot study to settle down a protocol in order to treat these burn scars. You see here the first step where we actually use a deep CO2 mode, ScarFX or DeepFX, in order to introduce scar remodeling. And then in the second pass, we actually fully ablate these little irregularities of a burn scar. In a third pass, which is not shown here, we actually covered the whole area with a superficial CO2 in order to further smoothen the area. This was a protocol that we developed together with Matteo Tretti-Clementoni, and we actually could confirm that this protocol seems to work in comparison to an untreated area as depicted here. And what we could see is that over a time course of 6 months, we saw significant improvements based on the Vancouver SCAR scale, for example, for pigmentation, vascularity, pliability, and height. And if you look at the more objective measurements, we also could demonstrate highly significant values for the improvement of, for example, scar volume and scar texture. More important, I think, is the clinical approach. So we did an additional study using a total of 3 treatments using this protocol in different patients with burn scars. And there's just one picture out of the study where we actually could demonstrate that also from a, let's say, cosmetic point of view, these scars actually did significantly improve over a course of 1 year after the last treatment. It is not only cosmetics, it's also more the medical benefit that patients do have after CO2 fractional lasers. This is a patient of Matteo Tretti-Clementoni, and you see here that these patients actually have a big benefit when it comes to the stiffness of the scar. You see an improvement in the range of motion in this young boy. And this is, I think, in the very end, contributing a lot to significantly improved life quality in these patients. Nevertheless, a fractional CO2 laser is not a replacement for plastic surgery or reconstructive surgery. I think fractional CO2 lasers kick in as soon as there is not more room for example, surgeries in order to improve these contractures. We already heard about lasers-assisted drug delivery, and this is nowadays an approach that I think is going hand in hand with this fractional laser CO2 treatments of scars. There are a couple of studies, for example, using the PRP directly after the CO2 laser treatment, or a study of Ophir Arzi, who you just heard, who is using the topical triamcinolone acetonide in combination with 5-fluorouracil in order to use it in an additional way to improve the scarring after the CO2 procedure. The idea of laser-assisted drug delivery is that you use an ablative laser, mostly an ablative laser, to help an active drug to penetrate into the scar tissue. And there are different drugs that you could use. For example, the botulinum toxin for when you have a lot of tension, the 5-FU, the triamcinolone acetonide, and the PRP. These are the most popular approach when it comes to hypertrophic scarring. What is nice with laser-assisted drug delivery is that you actually only need a very small density in order to help the drug penetrating. Though this goes hand in hand with scar laser treatment, as I mentioned earlier, you don't want to have high densities when it comes to scar treatments because you don't want to overheat the tissue. So with laser-assisted drug delivery, low densities are fine in order helping the active drug to penetrate. This is sufficient. And this is just an example on a specific scar type that could benefit from this idea of laser-assisted drug delivery. You do the laser first, little densities, low energies actually, and then you apply the combination out of 5-FU and triamcinolone acetonide. You need to repeat that a couple of times, but here you have, I think, nice results without any significant side effects. Another approach is to really ablate an elevated scar, which works best in older scars, such, for example, the self-harm mature scars. Here, for example, we go first with an fully ablative approach in order to ablate elevated tissue. And then at the same time, we use a non-ablative erbium glass laser in order to further improve the whole area and to make the scar and the surrounding skin more even. Scars are usually pretty, let's say, monoform, but sometimes they have areas that would benefit from different approaches, such, for example, the scar here. Here you have elevated parts, so here we use, for example, drug delivery using an ablative fraction laser. You have slightly atrophic areas where we usually go for more an erbium glass laser in order to actually introduce collagen remodeling. And in the whole area, you could, for example, use IPL or pulse dye laser for scar fading. And some of these approaches you actually can do in one session. I usually do not combine ablative measurements with other technologies in one session, but non-ablative ones, such for example, erbium glass, IPL or pulse dye laser, you actually can combine within one session, having, I think, even better results. This is, for example, the idea in this young boy here. In the face, you don't want to use anti-inflammatory agents, such, for example, corticosteroids. So here we used a combination out of a non-ablative fraction laser and an IPL. And you see here that with time, after, I think, 5 sessions, you have nice results. Most challenging are actually the so-called keloidal burn scars, because they have a lot of different characteristics, such, for example, the inflammation, the increased cell proliferation as depicted here, scar maturation with structural changes, even some tensions, contractures, as I demonstrated here, and you have the big problem of color. And at the same time, you have frequently inflamed scars that are inflamed for a very long time. So you want to be very careful with too aggressive laser treatments, because you're afraid that these scars actually might become worse. So as Ophir already showed, it is sometimes very important to have the scar pathophysiology in mind when you're choosing the right therapeutics. And here, corticosteroids just have a very strong anti-inflammatory effect. In contrast to the previous talk speaker, I actually do love corticosteroids. You just need to use them in the right fashion. You shouldn't inject too much, and you really should only inject directly into the scar tissue. 5-fluorouracil is another drug that I like a lot when it comes to scar treatments. It is very strongly inhibiting the proliferation of fibroblasts, and especially in combination with these corticosteroids, it's a very effective approach to treat inflamed scars. The muscular lasers, mostly the pulse dye laser or some pulsed IPLs, are very effective in reducing the capillary network, by that generating some hypoxemia, by that reducing actually the inflammation, reducing the collagen production, and also from a cosmetic point of view, reducing the erythema. And then in the very end, you have the fraction lasers that we already have discussed, which are actually normalizing the dermal architecture of the scars. Just shortly about the injectables, we are frequently combining the 5-FU and triamcinolone acetonide in different ratios. It really depends a lot on the thickness and the activity of the scar, which kind of ratio we're using, and we actually do change the ratio over the period of treatment a lot. It has been well supported by different studies in the last year, so I think it's a very safe and effective approach. We did a lot of studies using this combination. I just don't want to state here that especially life quality in patients suffering from active keloids, using this combination for treatment has been highly significant. So I think it's very important for the patient to really go for this very relatively quick approach in order to improve these keloids. In the very end, nowadays, just flattening the keloids, I think, is not enough for the patients. They have higher expectations nowadays. So as soon as the inflammation is reduced, we can then slowly switch to lasers. I usually first do the vascular lasers on keloids and then switch slowly to the non-ablative fraction lasers. However, especially in keloids with patients of color, you need to be very careful. If you only use a laser a bit too strong, too high densities, too high energies, you might actually have a recurrence. So really go slowly and just step by step. In the very end, I think this patient summarized the complexity of scar treatments pretty well. It is a step-by-step procedure. You need time, you need the patience of your patients. And you see with this patient here that it is important, especially in inflamed scar, that you want to go anti-inflammatory first, and then with time you actually combine lasers, and in the very end you can even go for a purely ablative fractional laser for the improvement of the texture. But I would do this only as soon as the inflammation is actually really significantly reduced. So in conclusion, especially when we're talking about elevated excessive scars, you really want to check for inflammation first. This has to be reduced first. You can use a laser, but mostly then for lasers is the drug delivery, so low energies and low densities. If the inflammation is gone, but you still have resulting erythema, you can use very nicely vascular lasers, such for example, pulse dye laser or IPL. And as soon as you're only left with irregular texture or contracture, this is for me usually the time where I start with ablative fractional lasers or non-ablative fractional lasers. However, you have some overlapping phases where you can kind of combine these different modalities. So very important, first define the respective scar type with regards to activity, the colors and the thickness. Combination of lasers with injectables during the inflammatory state is key, which means that if you want to start a laser and the scar is still inflamed, really at the same time inject or use the laser for drug delivery using some anti-inflammatory drugs. Some wavelengths you can actually combine within one session, especially non-ablative ones, and the main limitations till to date stays this is a keloids. Here you really have multiple sessions. It is also a matter of cost, which you have to communicate with your patients. And as I mentioned earlier, scar remodeling takes time. So it's also a matter of patience for both you, yourself, the treater, and the patients. Thank you very much.
Thank you very much, Professor Gogling, for the nice speech and the very interesting speech and topics. We have some questions from the audience. The first one is from Dr. Lucy Orchard from Worcestershire. She asks if you are reducing the inflammatory phase of healing. Isn't that an essential part of the healing process?
I think that is a good question. So it is... as she says, it's a reduction, so it's when you're speaking about scar treatments, it's always a modulation. You do not really want to reduce the inflammatory phase completely. You want to keep a certain balance, but I think in the very end, it is always a modulation. And I think what is very important when you talk about scar treatments, you have to monitor the scar every time you see the patient. So sometimes if I'm working with Asian patients, I actually do see that a certain laser treatment has been too aggressive. So the next time I see the patient, I see, okay, the scar is actually more reddish than it used to be. So you have to change your regime. So I think it is very important to monitor the results and the efficacy of the different treatments very closely.
Yes. And to customize the treatments on every single patient and every single kind of scars and phototype.
Exactly.
The second question is from Mark Brewin from UK. How do you determine between inflammation and erythema? Which is the difference?
It's also a very good question. I think it has very much to do with symptoms. So inflammation very frequently go hands in hands with pain, with pruritus, itchiness, also some changes when there's a lot of tension, for example, during sports. And if you only have pure erythema, the patients usually do not have any symptoms. The other thing is you usually see inflammation by the way the scar looks. It is very, let's say, it's bold, it's shiny. It is, you really see that it's nearly bursting, and a pure erythema is just very inactive. And this is how I do differentiate in between these two characteristics.
Yes. completely according to you. So if you don't have any other questions before concluding, let me thank all our speakers of this afternoon and all this audience, this nice audience. And let me show you some announcements if you want to share the slides. So please download our textbook on SCAR management. And if you want, you can see us at UMA conference in May in Paris. And please subscribe to our YouTube channel so you can recall all the webinars, also this of today, and you can have some information of the other future webinars. So please thank to all and a good afternoon and a nice weekend. Bye.